Hello, everyone. Thank you so much for joining us today to learn about and discuss management of complex short bowel syndrome in the pediatric patient. I'm Danielle Stam, a nurse practitioner and the clinical coordinator of the Center for Advanced Intestinal Rehabilitation at Boston Children's Hospital.
I'm Chris Duggan. I'm a pediatric gastroenterologist and nutrition physician at Boston Children's Hospital and the medical director of the Center for Advanced Intestinal Rehabilitation.
And I'm Tom Jaksic. I'm the pediatric surgeon and the surgical director for the Center for Advanced Intestinal Rehabilitation at Boston Children's Hospital.
I'm Alexandra Carey. I'm also a nutrition attending and gastroenterologist in the Center for Advanced Intestinal Rehabilitation and the director of the Home Parenteral Nutrition Program at Boston Children's Hospital.
And we all work alongside a team of interdisciplinary colleagues to provide care to over 300 patients with intestinal failure. Today, we're excited to share some of our experience with this group. We're going to focus our discussion today on a few key areas of treatment that are particularly prominent in our field and that we feel make a substantial impact on patient management. So with that, in May of 2019, teduglutide, or Gattex, was approved by the FDA for children with short bowel syndrome aged 1 year and older. This has been an important development in our field and has provided us with a novel therapeutic option for patients undergoing intestinal rehabilitation. Dr. Duggan, you were an investigator on the multi-center clinical trial of teduglutide, which helped inform eventual pediatric approval for this med. Since that time, you've had the opportunity to prescribe this medication in clinical practice for a growing number of patients. Can you please tell us about the rationale for using Gattex and also what considerations one might make when considering a patient for this medication?
Sure, thanks, Danielle. And really, as you mentioned, it has been a very exciting time here for those of us in the field of short bowel syndrome, because teduglutide really represents the first medication approved for the specific indication of intestinal failure. The medication, also called Gattex, is an analog of a naturally occurring hormone in the body called glucagon-like peptide 2, or GLP-2. And this hormone is normally synthesized in the distal small intestine and secreted by the enteroendocrine cells there. Now, as you know, the distal small intestine is often a portion of the bowel that is lost due to various conditions that lead to intestinal failure. So one could even consider some of our children to be hormonally deficient in this important hormone that leads to intestinal adaptation. The medication has been altered by the pharmaceutical company to increase its half-life. So normally, native occurring GLP-2 has a half-life in a few minutes, but the drug has a half-life of several hours. After many studies in animals and healthy adults and in adults with short bowel syndrome, we at Children's and at several other centers performed randomized trials to document the safety and efficacy of this medication over 12 and then 24 weeks. And the US FDA, as you noted, approved the medication for its use in children. Some of our patients, because they were participants in these early trials, have therefore had access to this drug for several years before it was widely available. You asked about the rationale for its use. Well, basically, the hormone leads to increased mucosal surface area of the small intestine, including longer villi and deeper crypts, so that there's more efficient absorption of fluid, electrolytes, and nutrition, which hopefully will lead to an ability of our team to reduce parenteral nutrition and parenteral intravenous requirements. The current labeled indication for this medication includes children who are at least 1 year of age, who are at least 1 year after their major intestinal surgery, and who are dependent on some form of parenteral nutrition or IV fluids. And we have nearly 30 children here at Children's Hospital who are receiving this medication. I should point out that our colleague, Dr. Lisette Jimenez, is leading a multi-center study to evaluate the long-term safety and efficacy of Gattex that has just begun. As with all medications, the decision to start GLP-2 analog is a discussion best had between the family, the parents, the children, and the treating team. The medication, as you know, is administered through a daily subcutaneous dose, but the volume is quite small. People say that it seems more like a mosquito bite than a bee sting or a vaccine. And in addition, as with any growth-promoting agent, there is a theoretical risk that polyps of the gastrointestinal tract might occur. I should also note that Dr. Ali Carey in this seminar is leading a study in which another GLP-2 analog with an even longer half-life and therefore only needs to be administered on a weekly basis versus a daily basis is being evaluated. So because the drug is new to the market, we routinely follow our patients quite closely. And that means we see them on a monthly basis, either in person or via Zoom for the first 6 months, and then every 2 to 3 months thereafter. And during these visits, a history, physical examination, and select laboratory monitoring are done to evaluate medication safety and efficacy. We also monitor for the possible side effects of possible polyp formation with stool guaiac tests and GI endoscopies. So it's a really exciting time. I agree that the drug has promise, and we're interested in looking at other cutting edge therapies for intestinal failure.
Thank you so much for that explanation. Another exciting development over the past 2 decades has been in the area of intravenous fat emulsions. With the availability of Omegaven and SMOF, in addition to intralipid, there are now many factors to consider when we think about intravenous fat. Specifically, selecting the optimal IV fat type and dose has become an important consideration in prescribing parenteral nutrition. Dr. Carey, can you please provide some background on the options that exist for intravenous fat emulsions and relevant dosing considerations?
Of course. Thank you so much, Danielle. So in fact, the most common IV lipid emulsions used at Boston Children's Hospital in children with intestinal failure requiring prolonged PN is currently SMOF lipid, followed by Omegaven and then intralipid. In our outpatient home PN program, we follow about 140 patients on PN. So that's 65% on SMOF lipid, 30% on Omegaven, and about 5% on intralipid. Which is much different than years past. It is very important that if you are prescribing PN or following a patient on PN who is receiving IV lipid emulsion, you understand what that lipid emulsion is, how to dose it, and what it's composed of. So I would like to review the differences between the 3 that Danielle mentioned. So first, we have intralipid. That is 100% soybean oil, or made up of omega-6 and omega-3 fatty acids. Now, Omegaven is 100% fish oil, made up of the downstream products of the essential fatty acids, linoleic and alpha-linolenic acid, but really have more dense EPA and DHA as well as arachidonic acid. Then SMOF lipid is a composite lipid emulsion, which is 30% soybean and MCT, 25% olive oil, and 15% fish oil. All 3 of them have a glycerol backbone, have egg phospholipid, and have some phytosterols. We used to think that Omegaven had no phytosterols, but we learned that the fish that Omegaven are made from actually eat algae and plankton and have some phytosterols, but that's significantly less compared to intralipid and SMOF lipid. And the phytosterols are one of the major reasons why we think that the IV fat is hepatotoxic to our patients on prolonged PN. So again, Omegaven has the least amount of phytosterols, very minimal. All 3 of them have vitamin E, but Omegaven and SMOF lipid have a dose of vitamin E much greater than intralipid. Now I'm going to focus on SMOF lipid. This was FDA approved in 2016, but for adults. Most people don't realize that it is not FDA approved for children in the United States. In the US, it's actually used off-label for kids and dosed using foreign package inserts and recommendations that vary from country to country. So that's incredibly confusing and can actually result in poor growth and essential fatty acid deficiency if you don't understand the right way to dose your patient. And dosing strategies for SMOF lipid is variable based on their age, the anatomy, the percent of enteral and oral nutrition, or if they have an ostomy. It's really important to understand this. SMOF lipid is suggested to be preferable to intralipid if you're on prolonged PN and you're an infant due to the presence of fish oil, vitamin E, and a decreased phytosterols, as we discussed, with the theoretical benefit of improved hypertriglyceridemia, improved inflammatory cascade profile, and decreased risk of IFALD. But at Boston Children's, even though it has that theoretical benefit, we certainly see infants who develop cholestasis on SMOF lipid and develop hypertriglyceridemia. So that's just important to track and monitor. So again, SMOF lipid should be considered as an alternative alternative to low-dose intralipid for any patient with anticipated prolonged PN use, greater than 21 days, and a risk for IFALD. I wouldn't use it in a patient that already has cholestasis. I would probably select Omegaven for that patient. And it's really ideal in kids with poor growth on lipid-restricted protocols, so low-dose intralipid or Omegaven, which is dosed similar to intralipid, with a need for extra calorie provision from lipids due to high GIR or glucose infusion rate. Again, I probably wouldn't use SMOF with severe hyperlipidemia or severe disorders of lipid metabolism. Now, if we focus on Omegaven, it is very exciting that out of these 3 fats, it has been approved by the FDA for use in children as recently as 2018. It's typically dosed between 1 and 1.5 grams per day, but in a 2-in-1 solution. So unlike the other 2, you have to have 2 pumps and 2 bags. And not a lot of people realize that. Hopefully in the future, we'll have compatibility and solubility data where we can make Omegaven fit into a 3-in-1. So this is a great source of calories and fatty acids in pediatric patients with parenteral nutrition associated cholestasis. It's supposed to inhibit, or it's been reported to inhibit inflammatory gene induction, but it's not indicated for the prevention of IFALD. So we use it most commonly in patients with intestinal failure who are greater than 21 days old with a direct bilirubin greater than 2, who receive PN for greater than 2 weeks and do not have some other intrinsic liver disease contributing to the cholestasis. Who it doesn't really work on are patients who are critically ill with advanced liver disease. So starting it in those patients most likely won't result in the reversal of cholestasis. Now, finally, back to intralipid. This one is dosed at 0.5 to 1 gram per kilo. So if you're an older patient, a young adult with intestinal failure on PN and you have normal bilirubin, you may have a history of remote IFALD, but you have low PN calorie needs, maybe you're fluid restricted or you require a concentrated PN solution, this is a great choice for you. Again, in our program, only about 5% of our patients are on intralipid now. Another benefit is we can dose it 3 times a week in a 3-in-1 solution. But I would really avoid doses greater than an average of 1 gram per kilogram per day if you are on chronic PN regimens with intestinal failure. So that summarizes a review of the 3 most commonly used IV fat emulsions, and I will hand it back to Danielle.
Thank you so much, Dr. Carey. Dr. Jaksic, with improved survival of intestinal failure patients on long-term PN, we've started to enhance our focus on preservation of central access. What are some specific strategies that you employ in your practice to support this goal, and what other specialties in the hospital might be able to help support these efforts?
Thank you for that question, Danielle. Along with the changes over the past 20 years with an incredible increase in long-term survival of intestinal failure patients, we have also seen an increased ability to maintain central venous access, which, as you point out, is necessary for the preponderant portion of our patients who require a long-term rehabilitation time frame. And the principles of maintaining a long-term IV access without losing it include not sacrificing any veins when they are when insertion is accomplished. That usually means percutaneous techniques where we do not tie off any of the vessels. And additionally, if a patient needs a new central line, we try to preserve the site where the central line is and use wire techniques to change these lines and not cause new veins to be subjected to injury. And that allows us to preserve access over time. The workhorse line is a single lumen silastic cuffed line. These have multiple advantages. They're very easy to work with. They're pliable. They tend not to kink. There are repair kits available for them. So if there's a break in the line, then we do not need to necessarily put in a new line. And further, they're ethanol compatible. So we are quite keen on limiting infections, and these lines are resistant to breakage that can sometimes occur with the utilization of agents such as ethanol. I think one of the Major changes over the past decade has been the interaction that we have with our colleagues in interventional radiology. We do have a list of patients that are extremely difficult IV access patients. We meet regularly to discuss those. Interventional radiology has the ability to dilate veins which have become stenotic, which is very helpful to us, and can sometimes put in lines where a novel type of a collateral vein needs to be used to tunnel the line centrally. I think all programs should have that type of collaborative care. Rarely we use portacats. For instance, some of our patients who are intercollegiate athletes obviously prefer these. There are challenges with this. Occasionally, a patient will prefer a PICC line over a tunneled cuffed silastic line. I think it's important to note that we have had lines in as long as 10 years without a requirement for exchange or even repair. And similarly, our nursing teams and our coagulation teams work very hard at teaching our patients appropriate care. And we do have a simulation unit to help with that. Overall, the most exciting thing, I think, is the interdisciplinary care with interventional radiology. And I think that is a hallmark of our program as a whole. And Danielle, I was wondering if you might expound on that further.
Yes, I would be happy to. I'm really happy to be able to talk about interdisciplinary management and intestinal failure. It's a topic that I feel very passionately about, as I really see a positive impact on patient experience. And there is evidence to show that it significantly improves patient outcomes. When I think about interdisciplinary management and why it's valuable for this patient population, I find it useful to consider the journey that our patients take through their chronic illness and the various inputs that they receive along the way. From the time of their initial diagnosis, leading through an often prolonged hospitalization and eventually into very long-term outpatient management, which often is punctuated with hospital readmissions for various complications, patients and their families are getting inputs from myriad experts and various specialties. The value of an interdisciplinary approach is that it takes these many silos of experience and it integrates and coordinates them. This is really valuable, not only for the patient and family, but also for the clinicians themselves, as they can all learn from one another and develop their knowledge. When this model is used effectively, we're also able to create a holistic plan that pulls on all these different experiences, and then we can deliver that streamlined plan to the patient and their family. So what is this core interdisciplinary team? So typically at most centers, such a team is comprised of a pediatric surgeon, a gastroenterologist, a nurse coordinator, a pharmacist, a social worker, and a dietitian. Sometimes plus or minus some of those, but oftentimes including all of those. The nurse coordinator in this model often serves as the frontline manager of day-to-day triage concerns and care management, accessing different members of the interdisciplinary group as needed. A specialized nursing care in this model is really extremely important in providing support for safe management of central venous catheters in the home, enteral feeding tube training, and management of complex skin care. And with experienced nursing care in such a program, patients tend to have smoother discharges and better experiences in managing highly complex care in the outpatient setting. Dietitians on such a team carefully track patient growth, and they contribute very significantly to PN management and enteral feeding plans. Surgeons and gastroenterologists work hand in hand to make decisions about diagnostic workup and addressing complications that may arise. And social work and case management are vital to providing support to patients and families as they navigate the very complex world of chronic illness, both in the hospital and outpatient. pharmacists are extremely important also to review highly complicated medication lists and PN formulation. In addition to this typical core team, there are many other clinicians and providers that give important support to patients and are part of the interdisciplinary group as well. Some examples are neonatologists, who are often extremely key in the primary management during the early phase of diagnosis and treatment when patients are in the NICU. Psychologists are very important throughout the lifespan, often helping support patients and families through different aspects of medical coping. Radiologists are very helpful in interpreting radiologic studies in a highly complicated post-surgical anatomy, and speech language pathologists are an important component of the team to evaluate and support oral feeding. In addition, it's helpful to have the involvement of a transplant surgeon and hepatologist, because some patients do eventually require transplantation. So with that, I wanted to think about the evolution of the intestinal rehabilitation program over the past 20 or more years. So 2 decades ago, early versions of intestinal rehabilitation programs were really focused on supporting patients as they awaited transplantation, as this was the likely path that patients were expected to follow. But in recent years, the focus has really shifted heavily to long-term intestinal rehabilitation. And thinking about that, it's important to remember that most patients really do reach enteral autonomy when they're given adequate time and support to do so. Research actually shows that 78% of patients followed in a dedicated intestinal rehabilitation focused program eventually achieved enteral autonomy. Furthermore, significant advancements in the way in which we manage home parenteral nutrition has led to successful long-term home PN patients leading happy and fulfilled lives. So an interdisciplinary program, in conclusion, really supports improved outcomes for patients and better sharing of information among clinicians. With that, I would like to transition to some questions from you, our audience. We have had the chance to review some of the questions that were submitted ahead of our discussion, and I will begin with one of those. Dr. Jaksic, how has the prognosis of children with complex short bowel syndrome changed in the past decade? Are there ways to mitigate the long-term risks of short bowel syndrome by intervening in the first year of life? I think you have to unmute.
Beg your pardon. Thank you for that question, and also telling me to unmute. The prognosis has changed markedly over the past decade or so. Long-term survivals in patients with severe intestinal failure now exceed 95%. And with that, we have learned some important lessons. Firstly, in the first year of life, it is important to preserve as much small bowel as possible and to do operations in such a way that that bowel is preserved. Then once that is accomplished, reestablishment of bowel continuity promptly allows these patients to attain enteral autonomy in as rapid a manner as possible. Our goal is always to obtain enteral autonomy if in any way possible. Sometimes it may take many years to accomplish that. The issues with bowel lengthening are now somewhat less important in that we do have GATTEX, so bowel lengthening is a third-line therapy. In the majority of patients, reestablishing bowel continuity and careful rehabilitation techniques and intervening when there are complications allows them to really make good strides. Chris, do you have any comments regarding medical management?
No, I think you've touched on the points quite well, Tom. I do think that in complementary factors with respect to multidisciplinary care, I do believe that there are some data to suggest indeed that the state of the art currently is for these complicated kids to really be taken care of at referral centers or in consultation with the referral center. Certainly the North American Society for Pediatric GI Nutrition statement to that extent supports that as standard of care. So I know you would join with me to say that some of the best parts of our professional lives are getting calls from folks with a complicated patient to say, hey, can I run a patient by you? And that's been really helpful, and I think has helped shift the curve nationally.
Great. We just got a question for Dr. Carey. How would you approach a fluid-restricted NICU baby with intestinal failure who isn't growing well, or you can't seem to increase PN calories due to fluid restriction and/or compatibility issues?
That's a great question, and compatibility issues are a real thing with small lipid and omegavin, because we have the less amount of data to suggest that those IV lipid emulsions are compatible. So oftentimes you have to place a peripheral IV to give IV certain types of IV fat. But my first question would be, is the baby cholestatic? Does the baby have IFAL? If the baby is significantly cholestatic, I would, and is older than 21 days and is not an ultra preemie, if the patient is cholestatic, I would use omegavin, but I'd probably push the dose up to 1.5 grams per kilo per day, and make sure the GIR is maximized closer to 15 to 20, assuming there is not hyperglycemia or spillage of significant glucose in the urine. If there is no cholestasis, and you're able to increase the small lipid, even with the fluid restrictions, to 3 grams per kilo, that will help the baby grow. But if the fluid restriction is such that giving a dose of 3 grams per kilo, a minimum dose of 3 grams per kilo of small lipid is not possible from the fluid restrictions, I would try to use intralipid, because that gives you the most bang for your buck with respect to essential fatty acids, as long as the baby's not cholestatic. And you can go up higher than 1 gram per kilo on intralipid for a short amount of time if the baby's not cholestatic. But again, that's going to be a risk the longer that you use it. So I hope that answered your question. And if Dr. Jaksic or Dr. Duggan also has anything to add, I'd be interested to hear their thoughts as well.
My only comment, Ali, I fully agree with what you say, is that if one has to meet one nutritional goal in critically ill patients, is protein requirement.
Yep.
So that really should be the focus of nutrition in the intensive care unit.
Yes, we try to maximize not only sugar and fat, but definitely the protein.
Great. I'm going to move to another question that was submitted in advance of this discussion. The question was, do you use probiotics? If so, what kind and for how long? Dr. Jaksic, would you like to start with the comments on that, please?
Yeah, I think probiotics warrant caution. We have had patients with central lines who have manifested lactobacillus septicemia, and we tend to avoid probiotics if the central line is in situ. Chris?
Sure, no, I totally agree with that, Tom. And I guess I will say that on the other hand, we do as a community, do believe you are what you eat. Certainly some of the improved outcomes that we see in infants with short bowel syndrome who receive human milk perhaps is related to the fact that the prebiotic composition of human milk engenders a healthier milieu in the gastrointestinal tract. So the idea that a lactobacillus or bifidobacter predominant microbiome is associated with better outcomes is entertaining. The question is, how do we engender that in children who have short bowel syndrome? So the practical implications are that once the central line is out, we would consider probiotic supplementation, but it is a perfect example of something that really hasn't been tested to be efficacious in short bowel syndrome. It's probably safe once your central line is out, but it's not clear it's helpful.
Great, thanks so much. We just got another question for Dr. Carey. This one states, we routinely use fish oil-based lipid emulsions in our high-risk infants. We routinely get fatty acid profiles in these infants, and we often see very high EPA and DHA levels. I was wondering if you can comment on the clinical implications of such high levels, especially in the neonatal population.
That's a great question. there is not a lot of published literature about reference ranges in neonates for these levels. So we don't, we observe them and we follow them closely. But I know that if you're using fish oil, you're delivering a larger dose of EPA and DHA as well as arachidonic acid. So patients on omegaven have higher levels of those compared to interlipid or SMOF where you're delivering more the downstream products. So if you're on interlipid, you have a low level of ALA and LA, but you're going to have a higher DHA and EPA. As far as the clinical implications of such, I am not sure about that. And maybe Dr. Duggan and Jaksic can comment.
No, I think you summarized it quite well. Obviously, again, harkening back to the how fatty acid profiles differ between formula-fed and breastfed infants might give us some clues here. And a number of studies have been done to evaluate whether neurodevelopmental outcomes and ophthalmologic outcomes are improved with a omega-3 predominant profile.
I will say we do not discontinue omegaven if we see a very high level of such. We continue to monitor.
Although sometimes, in the long term, and quite often actually, we will transition to SMOF lipid in our patients just because it allows us to have a 3-in-1 formula for home PN, which is very handy. And we published results to show that is quite a safe intervention once the IFALD has been quelled.
And I would agree with that.
We just got another question for Dr. Duggan regarding teduglutide. What would be the length of therapy with the GLP-2 analog? Are changes in intestinal mucosa reversible when the drug is discontinued? Is there any data on this?
Well, those are really excellent questions, and indeed the answers are unclear. We've had at least 2 patients who we've tried to, once they've had a desired effect of the GLP-2 analog, namely they've weaned from parenteral nutrition, we've discontinued the medication, and unfortunately this patient suffered from recurrence of diarrhea and weight loss, so we reinstituted the drug. Certainly the adult data would suggest that the absorptive capacity of the bowel sometimes reverts back to baseline once the drug is discontinued as well. Obviously, as pediatricians, we're hoping that because adaptation is an active process, perhaps regression to the mean after discontinuation of the drug will still leave them with a better absorptive status than before drug therapy. But that's the reason we're studying these children in a natural history experiment to see if those are considerations. I don't know of any data to look at the before and after again histology of outcomes. Certainly in children, as you can imagine, the ethics of performing repeated endoscopies with biopsies are a little bit tricky.
Great, thank you. We'll keep going for one more minute here because we still have some questions coming in. This one is for Dr. Jaksic. Could you please expand on lengthening techniques in short bowel syndrome in situations where it may be indicated?
So there are 3 general indications for lengthening operations. One is failure of maximal medical management to increase enteral tolerance. And now one of the exciting intermediate steps is the use of teduglutide. However, a lengthening operation can certainly be considered in patients in whom Gattex is thought not to be useful, teduglutide, or in patients in whom teduglutide has been unsuccessful. In this scenario, one can anticipate 2/3 of patients to improve their enteral tolerance and about 50% to come off parenteral nutrition totally. This usually occurs relatively rapidly within 3 to 6 months of the a lengthening operation. The second indication is refractory bacterial overgrowth with a dilated loop of bowel, where we do not want to sacrifice intestinal mucosal surface area. One can do a segmental bowel lengthening. And lastly, in children with extreme short bowel syndrome with a very dilated intestine, for instance, and an atresia, where there's a less than 20 centimeters of small bowel available. Rather than lopping off a portion of that bowel, one can lengthen the bowel using an operation such as a step operation, and then do a primary anastomosis. The question always arises, which lengthening operation should be done? There are two. There's the serral transverse anaplasty, or the step operation, and the Bianchi. There are a few other much less used procedures. The step operation is by far the easiest. So in general, in surgery, we tend to use the easiest operation that will work, and that would be the step operation, which is the most popular bowel lengthening operation in the world now.
Great, thank you so much. We have a few more questions, and I think we all have time to stay on for a few more minutes. So the next one is for Dr. Carey. Have you seen increased PICC line clots or failure with SMOF?
Thank you for that question. And I think that question highlights the importance of tracking your outcomes in your program, so that as an institution, you can also see if one of your therapies is leading to a change in outcome. So in our program, we do track line complications and the need for line rewires and replacements, and we have not seen an increased incidence at this point with SMOF and have not really seen any difference between the different intralipids with respect to forming either fibrin sheaths or clots or precipitates. I will say, though, it's so important, like Danielle mentioned, to have a pharmacist as part of your team, because our pharmacists do analyze the compatibility and solubility curves of our patients before they come into their clinic visit. And we have published on this. We find a great deal of errors or issues with solubility and compatibility of solutions that are 3-in-1 admixtures, which can contribute to precipitates and increased clotting. So I guess just a plug for tracking outcomes and involving your pharmacist to help review the PN compounding records.
Great. Another question that came in, maybe we'll start with Dr. Jaczyk's response to this. When do you anticipate intestinal transplant in these patients?
So that's an excellent question. There are certain patients who are referred late, in whom there is concomitant liver failure and intestinal failure. And in those patients, transplantation is their salvage option. There is a second group of patients, which is an even more interesting group, where an isolated intestinal transplant may be indicated for improvement of quality of life. And that is something that we anticipate will increase in terms of referral for intestinal transplant. We do our intestinal transplants and multivisceral transplants, as you know, in-house. It is a very interesting thing for the future to decide how we can help the patients make educated decisions of whether to continue with long-term parenteral nutrition or to try an isolated intestinal transplant.
Can I just add that occasionally we've had people who've lost vascular access, and that's been one rare indication for referral to the transplant center, and harkens back to your comment earlier in the webinar where you said, maintaining line sites is really a crucial aspect of successful care.
And as we stated before, there has been tremendous progress in that regard. And as Chris says, that is a very, very rare indication for transplant now. But I think the huge question will be, how can we help patients assess the risks and benefits of a transplant better? And there are certain patients and certain families that absolutely want to have a transplant. And technically, the operation has been well worked out. There are still problems with long-term immunosuppression.
We have another question here that we can ask. This is from the University of Alabama at Birmingham. Hello, back. We've modeled our program in many ways after yours. Thank you. You're welcome. We still struggle with our CLABSI rate. Any suggestions beyond ethanol locks and patient education? I think many panelists may have comments on this, but maybe we can start with Dr. Carey.
Thank you. That is a really tough question. I'd first love to hear if we had more time, more about your program, so I could understand exactly how how many patients you have, and a little bit more about their demographics and your program's capabilities. I know that you modeled your program after hours, but I would be interested to know what your teaching session is like. We published 2 years ago a paper on, and maybe Dr. Duggan, I know you probably have access to this, you could share it, or one of us can share it later. It's a 5-session teach where we partner with home infusion company liaisons. And once a patient has been deemed to go home on PN, we will start a 1 to 2 week training process in the hospital with the family, the bedside nurses, and the infusion company liaisons to teach the parents and empower the caregivers how to use the pump, how to troubleshoot for anything that may come up in the home setting. We also use a simulation lab where we bring the family, the caregiver, and the patient, if they're able, to a lab where they get to practice different scenarios with line care and different, like say the patient vomits on the line. What do you do in that situation? How do you clean the line after that? And then also really doing root cause analysis to see where is your pain point? What is the most common cause of your CLABSIs in your population? We recently did this, and we'll be presenting it at NASP again. One of our nurse practitioners is publishing on our root cause analysis on ambulatory CLABSIs, and we found that most of them had to do with contamination of the connection of the PN catheter. And now we are using a product called ValGuard to cover the connection to decrease the risk of contamination from vomit, soiling, or stooling onto the line. So I think it's a very complicated question, and there's probably a multitude of different answers. So again, I'd like to turn it over to Dr. Doug and Danielle and Dr. Jackson if they have anything to add.
Yeah, I mean, I think that was just to echo what you're saying. I think really the really impressive and robust teaching that's done by nurses to help not only support patients delivering safe PN care at home and also disseminating safe practices within the hospital, and also just the rigorous root cause analysis has just been so vital to identifying these potential pain points so that we can target our interventions. I think we're just about out of time. We really appreciate all the questions. We're so appreciative that you all took the time to join us today to hear about this population of patients that's so dear to us. We would be really happy to hear from you if you have questions about pediatric intestinal failure management. I believe there'll also be in the chat an opportunity to submit your questions via email, and we're happy to try to get back to those, the ones we didn't get to today. You'll find contact information also for our program, both phone number and email address in the chat. Thanks again for your attention, and have a wonderful day.